Who is out in Durban, of course, for us, waiting on the Minister of Social Development and the MEC as we build up, or rather begin, this conference. To this now, South African TB research is influencing global policy changes for the treatment of drug-resistant variants. The World Health Organization has announced key changes, with treatment time slashed from 18 to 6 months. I'm joined now by Dr. Norbert Ndjeka, the Director of Drug-Resistant TB from the Health Department. A very good morning to you, Doctor, and thank you so much for your time. I want to touch on that 18 to 6 month slashing of the time period. What influenced that?
Yeah, thank you so much for inviting me. Good morning to you and to all the viewers. There have been a lot of research going on in South Africa, both in the TB program and outside the TB program. I refer to clinical trial by our local experts. And over the years, we've been having this idea that probably treating MDR-TB, which is tuberculosis resistant to ordinary tuberculosis treatment, we've been thinking that probably treating for 6 months is a good idea. There's been research around that, and we've been really participating. In fact, the first one, the next study, was a fully South African study in collaboration with TB Alliance. It looks so good, too good to be true. So that has been replicated in South Africa, but also across the world. And now the World Health Organization has agreed that, yes, it makes sense to go that route, because 9 out of 10 people in that regimen, fewer medicines, 3 of them, and they do very well. 9 out of 10 are cured after 6 months of treatment. Wow. When we gave 2 years, we brought it down to 18 months. We still have just 6 out of 10. It's too low, but we come from a background where we cure only 3 to 4 out of 10, like 12 years ago. So it is a big news. Of course, we are really excited.
Doctor, TB is, of course, we all know this, one of the most deadly diseases in the world. But how prevalent are the drug-resistant variants? How bad are those cases?
Yeah, the variant, resistant variant, which we call multi-drug resistant, as I said, or rifampicin-resistant tuberculosis, it's less. We get less cases, less number than the ordinary TB. For example, last year we had on average 200,000 ordinary TB patients, and in the region of 7,000. We used to have 10,000 a year, but it's costly to treat. To treat that small group, we spend more money than the bigger group where you have 200,000 people. It takes long to treat. We give them like 23 tablets a day. And now with this new regimen, when we start implementing, hopefully from September, between September and December this year, we'll move the pill burden from 23 tablets a day to 23 per week. So that's a big thing, really bringing down the duration, bringing down the number of pills, saving a lot of money for the nation, and curing more patients. We're hoping that we'll cure many more than what we did before. So it's really exciting.
I mean, some would say probably it only makes sense for a South African team to be leading the research, because TB, again, is one of the most deadliest diseases in this country, one of the most deadliest on the African continent. And of course, it has a lot to do with the fact that the treatment of it, the resources for the treatment of it, we are not, as a continent, more privileged to have those resources. So rather, let me put it this way, how is Africa doing in the fight against TB, the fight against these drug-resistant variants of TB? Are we still quite far behind, or are we getting there?
Africa is doing very well. When you look at the proportion of patients with drug-resistant tuberculosis cured, when you look at the global average, you compare with the African average, you will see that Africa is doing very well. I mean, over the last few years, up until 3 or 4 years, the cure rate globally on MDR TB or resistant TB has been around 50%, and Africa has been there also around 50%. But now we start to move to 60%. But of course, we want to cure 90%. You know, we really want to cure more. So Africa is doing well. We cure more patients. But the biggest problem we have in Africa overall, laboratory. We don't have strong laboratory. Of course, South Africa is the strongest network, and we find probably half all the patients with resistant TB on the continent because of the strong laboratory network. But overall, Africa does not have strong laboratory infrastructure, and a big number of patients with MDR TB are missed on the continent, and that is a problem. We need to have more labs everywhere in sub-Saharan Africa so that we could find all the missing people with TB. Although we also have a challenge, I think up to 150,000 are missed. So for drug resistant, we miss probably 30% of, you know, what of patients they diagnosed, they're not even put on treatment. That's a big problem. But in the rest of the continent, they diagnose less than 50% of the estimated numbers, and that is a ticking bomb. We need to work hard as Africans to put labs, find the people collectively in all the countries, and link them to treatment, retain them in care, and enjoy this very good, very high treatment success rates that we are about to observe with the new regimen we worked very, very hard for.
Doc, I hope your call is being heard. I hope your cry is being heard for more labs across the continent as we continue to fight this disease. Thank you so much for joining us here on the South African Morning.